that was surprising to say. Now, Dr. Sunita Puri is going to put this in the context for us of palliative care and end-of-life care.
Thank you for having me here today. As a little bit of background, what I'm hoping to do is to provide a palliative medicine perspective on this very nuanced debate, particularly from my experience writing the End-of-Life Option Act policy at the University of Southern California. I think that the passage of this law says a lot about the landscape of end-of-life care generally in our country, not just in California. And provides a really good opportunity to talk about all of the options that are available for patients, not who are just at the end of their lives, but who have an advanced and symptomatic illness. Hospice and palliative medicine are both terms that have been relatively misunderstood, both by the public, but also by practitioners within medicine and nursing. And just a quick show of hands, how many people have heard the term palliative medicine and wondered what that meant? Good, I appreciate the honesty. My parents are here and they raised their hands too, so that says something. And there is really variable, not only understanding of these services, but also variable availability and quality of these services. Generally, and I'm going to talk about what palliative medicine is and what hospice is in just a second, but I do want to emphasize that these are services that are generally introduced fairly late into a patient's experience with advanced illness, even though they can do quite a bit of benefit. For example, the median length of stay on hospice was 18.5 days in 2013, when anybody with a life expectancy of 6 months or less in this country is actually eligible for hospice. And 34.5% of patients on hospice were on hospice for less than 7 days, which says a lot about how we approach the care of dying patients generally in our country. So the End-of-Life Option Act in California was passed within this context. And I see it as an opportunity to discuss and correct deficiencies in the option of care available for patients who are struggling with an advanced illness. And I asked myself as I was starting to write the policy, in what way could improved availability and quality of palliative medicine and hospice impact the cultural context in which this End-of-Life Option Act has passed? So you think about a palliative medicine consult, and a lot of people aren't sure what that means. What palliative medicine is an interdisciplinary team approach to the care of a patient and the family when there's an advanced illness affecting someone. Interdisciplinary means that there's a physician, a nurse, a social worker, and a chaplain to address all the various domains of suffering for the patient and the family that come with having a serious diagnosis. In terms of symptoms, we're experts at managing pain, nausea, vomiting, shortness of breath, anxiety, and depression, amongst others, that are sometimes due to the illness, but are sometimes also due to the treatment of the illness. And we also help facilitate advanced communication around goals of therapy, as well as provide emotional and spiritual support, because we recognize that suffering has many domains beyond the purely physical, and one of them is certainly the existential. We generally encourage people to consult earlier in the disease course, but because we have a culture of medicine that's very aggressive in this country, generally more is done before a pause is taken to see where the direction of care is going. It is worth noting that palliative medicine is not widely available. It's often in academic centers as opposed to community centers, and it's mostly in hospital settings as opposed to outpatient clinics or home-based palliative care. So there's a number of ways in which palliative medicine as an end-of-life option or option for care of patients with advanced illness has not achieved the penetration it should. I think of hospice really in this way, which is that it is a type of palliative medicine for patients in the last 6 months of life within the best judgment of 2 doctors. Hospice is generally provided at home as opposed to in a facility, with the exception of skilled nursing facilities where some hospice is provided. But people often hear hospice and they think of a beautiful facility, and that's just not the case in our country. You have the same interdisciplinary team looking to meet the same needs, physical, emotional, and spiritual suffering of the patient and the family, but it's generally done in the home setting. Patients can elect to stop hospice if they desire, if they improve and are able to go back on, for example, a clinical trial. But in general, hospice and palliative are equated, unfortunately, with giving up and doing nothing, which I really want to emphasize is not the nature of these services. And how we frame these conversations, including conversations about the End-of-Life Options Act, is critically important to how we guide our families and patients to making the decisions they will make. This is my little diagram of hospice as a type of palliative medicine. So the challenges facing these other options that have been in existence, hospice since 1982 when the Medicare hospice benefit was passed by Ronald Reagan, and palliative medicine more recently, really from the 1990s on, there are a number of issues with lack of access and variable quality of the services. Home-based palliative medicine is often really wonderful for patients who, for example, are early on in their disease course getting chemotherapy, but are homebound and need a team to come in and help with symptoms and, again, address the many domains of their experience, but home palliative is exceedingly rare. Hospice availability and quality can also differ greatly, especially geographically. At USC, we cover a really pretty wide catchment range of where patients come from, and there are times where it's hard to find a hospice agency for patients in remote areas. There are varying levels of physician comfort with discussing these options, in part because, just like many of our audience members, some of my colleagues have not really known what palliative medicine is. And that's not their fault. It's just a result of where we place our emphasis in medical education. And both fields, unfortunately, have at times been misconstrued as physician aid in dying. They're thought of as synonymous. So the passage of this law offers an opportunity to clarify all the options that are available and how we can talk about them in a meaningful way. And I think it's an opportunity also to improve all options available to patients with advanced illness. What I thought would be helpful to share with you is the result of the survey that I sent out to our physicians at Keck and Norris at USC, really trying to get a sense of their own attitudes, given that we operate in a context in general in medicine where hospice and palliative medicine are not very well understood, and approaching care of patients who are nearing the end of their life can be difficult. So now we have this act passed. What's the best and most compassionate way to get the feelings and experience of the colleagues that I have there, but also do what's right for our patients or make the right option available for our patients? So the couple of things that we added in, again in the vein of improving access to all possible care that patients can have at this stage, was we wrote in a mandatory palliative medicine consult for any patient at Keck and Norris looking to pursue the End-of-Life Option Act so that they aren't deprived of an opportunity to have any symptoms that they have that aren't optimally treated addressed properly. And by symptoms, again, not just physical, but existential, spiritual, and emotional as well. We also required the use of a navigator who's a social worker who does an initial psychosocial screen and follows the patient and family throughout the process of going through getting the forms done, seeing the attending and consulting physicians and a mental health specialist if necessary, again, to provide support and constant contact about how symptoms or experiences are changing. And we also required the completion of a POLST form and an advance directive so that, again, we use this law as an opportunity, as a vehicle to have people get good advanced care planning done. So just to share some of the feelings of the providers, I should note that of about 700 practitioners at our center, only 170 completed the survey, so it's about a 24% completion rate. But as a medical provider, do you support the End-of-Life Option Act? So 62% from multiple disciplines and many different levels of training said yes. Only 18% said no, and about 20% were unsure. Would you feel comfortable serving as the attending physician who's the one who would write the prescription? So 49% said no. Interesting, because even though a good percentage supported the act in theory, writing the prescription we get a different answer. 30% said yes, and 21%, again, about 20-21% unsure. Would you feel comfortable transferring care to a colleague who was agreeable to take on the attending role? Yes, 77%. Good. Unsure has dropped to 11%, and 12% say no. Would you feel comfortable serving as the consulting physician? 44% said yes, 35% said no, and again, that 21% really unsure. What would make you feel more comfortable about this act? So the ability for a physician to opt out, which of course is protected, and the mandatory palliative care consult was the second highest, as well as formal training on the program and the medications to be used. Some of the verbal feedback we got in focus groups was really that people weren't sure what they were prescribing and what the effects would be and whether it might actually harm someone. So really wanting to be informed was part of their own ethical reasoning about whether or not to participate. And I thought I'd conclude with the part of a statement from the American Academy of Hospice and Palliative Medicine, which takes a position of studied neutrality on the subject of whether physician aid in dying should be legally permitted or prohibited. And they do say efforts to augment patients' psychosocial and spiritual resources so they are better able to manage their suffering may make palliative treatments of physical symptoms more effective and may make these circumstances rarer. Nonetheless, some patients will continue to desire PAD. So I see this as recognizing that well-intentioned, highly ethical people stand on both sides of this debate, and what can we do about how the passage of this law, what is the commentary about all options that are available or inaccessible to people with advanced disease.